Well, in that case, I'll introduce the next speaker is Professor Mertens from Lyon. He's professor of neurosurgery. He's a world expert in pain surgery and in particular in ablative surgery. So it'll be a pleasure to listen to his talk.
Thanks a lot for this invitation and to have the pleasure to hear my colleagues and to have the opportunity to talk about a small part of the therapy of pain after nerve injury by ablative surgery. We are going to see that only a few number of patients could be treated by this kind of techniques. I have no disclosure concerning this presentation. I would like to put in perspective all the neurosurgical techniques we have at disposal. Actually, first of all, and we have heard with Dr. De Ruiter nicely, we have to think about as a first-line therapy, the restoration of the anatomy of the peripheral nerve. I think it's each time we have to face with patient with peripheral nerve injury, you have to think about this restoration before anything else of surgery. Then neuromodulation is a second line for this pain therapy with intrathecal pharmacotherapies, not very often used for single nerve lesion, but more for patient with wide painful territory. Also, electrical neurostimulation is the other option for neuromodulation. We were just talking about that. And then, as a third line, ablative selective techniques that we are going to talk about. So I would like to stress that the fact that, again, the first line is to think about restorative surgery. Is this surgery indicated and will be performed reasonably? Decompress, transpose, relocate, graft, transfer nerve. If it's possible for the patient, is a good news, because beside the improvement of the functions that we could have with these techniques, you have also a significant antalgic effect by this restorative technique. So you have to think about that always as first-line therapy. At the level of the peripheral nerve, or even, it's more difficult, at the level of the spinal roots, if it's possible. So the second line is neuromodulation techniques. We have just heard the possibility of spinal cord stimulation, and have the discussion was on this point. There are other targets possible at the levels of peripheral nerve, the dorsal root ganglion, the spinal cord itself. We have heard Dr. Hilmaz with this nice presentation concerning spinal cord stimulation, but also upper at the deep brain nucleus stimulation or even cerebral cortex stimulation in very selected case could be discussed as a therapy for peripheral nerve injury pain. But my topic today is to talk about lesional techniques. So there is immediately a question that we have to answer. Is there still a place for this technique today? Is there still a place to perform lesion for neuropathic pain due to peripheral lesion? Perhaps yes. Why? Because unfortunately, restorative surgery, neuromodulation are not always able to answer to the complex problem of neuropathic pain. And there are still patients that are not good responder to this technique. So we have to find something else. And in some, we are going to see that in some very selected case, lesional techniques could be discussed for this patient. But we need to demonstrate that this technique are able to meet certain conditions, like able to decrease pain to a Berber level, obviously, but with a selectivity that allows to minimize all functional consequences we are not to have to add any motor or sensory disturbances to this patient, and with a low morbidity. And at least we have to demonstrate that we improve the quality of life of the patient, because when you treat patient with pain, obviously you have to try to decrease pain, but the main goal, the terminal goal, is to improve the quality of life of the patient. And sometimes just decrease a little bit the pain is sufficient to give the patient the opportunity to have a new capacity in his daily life. And sometimes it could be more important than the decrease of pain itself. So you have to think about that also. So concerning these lesional techniques, what we have in hands, potentially a lot of techniques have been described in the past. I think no place in the peripheral system or in the central nervous system have not been targeted with lesional techniques. Peripheral nerve, vegetative system, nerve roots, spinal cord, brainstem, brain, even at the cortical level, have been targeted. But no, I have to say that these techniques are mainly, some of them only, are mainly devoted to treat nociceptive pain, mainly cancer pain. And there are still use of braisotomy lesion, chordotomy, tractotomy. It's identical to chordotomy at the upper brainstem level, tractotomy, so, and thalamotomy, and even cingulotomy are come back actually to treat some kind of cancer pain. But it's not the topic of today. Today, we try to face peripheral neuropathic pain, and as previously for nociceptive pain, we try to interrupt the nociceptive pathway with these lesional techniques. For neuropathic pain, we try to destroy some generators of the neuropathic pain. So actually, we have mainly only two techniques that could be proposed to some patients. It's at the level between the peripheral and the central nervous system. It's called the dresotomy surgery. And also for some selected patients, median thalamotomy could be discussed. So we are going to talk about these two kinds of techniques. First, dorsal root entry zone lesion. These techniques have been described by Marc Saint-Doux, 50 years old now, and he describes this area of penetration of the dorsal sensory rootlets in the spinal cord. You can see a diagram of an hemispinal cord section. At the level of the peripheral nerve and at the dorsal rootlets, all the sensory fibers are mixed. And there is only a spatial organization of these fibers when they arrive inside the spinal cord. They have to go in their respective pathways, ascending to brainstem and brain. So, as you could see, Marc Saint-Doux have described this organization, this spatial organization that was known in the animals, and he demonstrated that it was also the same in humans. The larger fibers that have to go in the dorsal funiculi that transmit epicritic superficial sensory function and conscious proprioceptive function go to the dorsal funiculi, and also giving a collateral inhibitory pathway that blocks the entrance of nociceptive pathways, that it's a gate control theory that shows that. These fibers, these large fibers, are the more medial fibers in the dorsal root entry zone. In the central part of this region, we have born in this diagram the non-conscious proprioceptive fibers that are able to elicit monosynaptic and polysynaptic reflexes that will control the muscular tonus. And the more lateral fibers, here in orange, are the more thin fibers, not myelinated or poor myelinated fibers, that are mainly nociceptive fibers that are going to make connection, a synaptic connection inside the apex of the dorsal horn. So Sindhu described a more or less selective lesion in the lateral part to interrupt initially this nociceptive pathway, mainly to treat cancer pain. But after knowing some experimental data in animals and even due to his work in humans during this kind of surgery, where he used microelectrode to register the neurons in the spinal dorsal horn, it shows that there is, like in animals, an hyperactivity of the deafferented neurons. If you operated, like in this case, patient with a complete avulsion of the rootlets, there is a complete deafferentation, and the neurons in the dorsal horn have hyperactivity that you could put in coincidence with the pain of the patient, with the paroxysmal pain of the patient. And what we give as Dr. Winfrey tell us to treat this patient, to treat medically this patient, is anti-epileptic drugs that try to reduce this hyperactivity, like this drug try to reduce the hyperactivity of the cortex level for epileptic fits, but it's more or less the same physiopathology at this level with an hyperactivity that you can try to reduce with these drugs. And if it's not sufficient, Sindhu proposed to make a deeper lesion and to destroy these neurons in the apex of the dorsal horns, and so to stop this hyperactivity that you can put in relation with the pain of the patient. So it's the rationale of this technique. The main indication is for avulsion of brachial plexus, of lumbosacral plexus also. And as you know, motorcycle accidents are the more cause of this kind of terrible lesion. With terrible pain, with very intensive pain, you can see some patients have an autophagy behavior, yeah, like experimental animals with sciatic ligation, they eat their paw due to the sensation of pain. And sometimes you can find that in your patient due to the intensity of the pain. And the patient asks you, oh, please, cut me the arm, no more, I don't want this pain no more. And you can explain that if you cut the arm, nothing happens. They still have pain because the pain is no more in the arm, no, it's in spinal cord and even in upward pain centers. So a case of a classical patient with brachial plexus lesion, with burning pain in C5, C7 territory, and with very high level paroxysmal pain in C5, C7, and with the classical treatment, as we saw before, of neuropathic pain, as you could see there. So what we could do is to propose rhizotomy, as this medication was not sufficient to reduce pain at a variable level. So it's a classical posterior approach, cervical approach for brachial plexus lesion. On the side of the lesion, you perform a hemilaminectomy, and then you open the dura, and you can see on this view, I can show you, the medial line is there, and you can see only a few dorsal rootlets at the C5 levels, and then no more dorsal rootlets. There is a complete avulsion. You can see the dorsolateral circus there without any rootlets. So it's a classical avulsion. And you can see, if you are a deeper resolution of the microscope, even holes in the spinal cord itself where the rootlets was there previously. So you have to open the pia over the sulcus and gently open the sulcus like a page of a book, and it guides you to the deep of the sulcus. You can see the gray matter of the apex of dorsal horn, and there we are performing microcoagulation has very low intensity. It's very important to perform very low intensity because if there is diffusion of the coagulation, medially you can have a lesion of the dorsal column and some problem with ataxia. And laterally, you have the cortical spinal tract and have some motor problems in the ipsilateral lower limbs. So you have to find, it's not so easy to find a bipolar machine that is allowed to perform very low intensity coagulation. Recently, some Italian groups proposed to no more perform coagulation, just make a mechanical lesion with opening the sulcus and the apex of the dorsal horn to avoid this morbidity. So you can see a post-op T2 MRI, and you can see the lesion, you can see the gray matter inside the cord at the cervical level, where the lesion was performed in the dorsal horn. What about the results? It's one of series with 29 patients, and we differentiate paroxysmal pain from continuous pain to in assessment of this patient with a very long follow-up at 10 years. And you can see that there is very good effect on paroxysmal pain, better than on continuous pain. And even at 10 years after dresotomy, 84% of the patient have still reduction of their pain, more of 50% reduction of their pain. What about complication in another series of 55 patients, mainly neurological disturbances due to lesion of the dorsal funiculus? If the lesion is go to medially, with 4 moderate ataxia in the ipsilateral lower limbs and 3 severe ataxia in this series that induce impairment of walking in this patient. So it's the more severe complication we can have. There is recently a review performed by an Italian group concerning dorsal root entry zone lesion for treatment of neuropathic pain, and concerning what is our topic of today, of peripheral nerve injury. Dresotomy is mainly performed in literature for brachial plexus avulsions. There are more than 700 patients reported with good outcome in 60% of the patients in all the series with more than 2 years of follow-up. And for phantom limb pain, the result is disappointing. Only 45% of the patient was improved. I said good outcome, more than 50% reduction of pain. And perhaps it's a pity that they don't differentiate phantom limb pain than from stump pain. That is not the same mechanisms. And in our hands, stump pain is more responsible to dresotomy than phantom limb pains. Phantom limb pains, the generator are no more in spinal cord, are more upper, perhaps at the thalamic or even cortical level, and dresotomy does not influence so much this kind of pain. So to conclude for dresotomy, what is the good part of dresotomy? It's efficient of paroxysmal pain and allodynia that could have patients with peripheral nerve injury with a long-term efficiency. You have a good reduction of opioids and all antalgic treatment in these patients. The follow-up is very simple. No long review that you have to have with neuromodulation, and it's not costly. You only have to have a microscope and a micro instrument. But the not so good part, it's important surgery with under general anesthesia with opening of the spinal canal. Though it's not it's heavy surgery. It's not for patients in bad condition and only for limited painful area. Obviously, you can perform this kind of surgery for large painful area. And it induces a thermoanalgesia. If the patient has still some sensory possibilities, you have to inform him or her that you will induce a complete thermoanalgesia in the territory that you are going to operate on. Then medial thalamotomy, it's only for very few patients. I have personally no experiences. The target here is a special target. It's thalamic nuclei, not the thalamic nuclei of the neospinothalamic part of the ascending nociceptive pathways. It is a discriminative pathway that going to the sensory cortex and said to you that you have an aggression, an nociceptive inputs at in a very precise territory of a type. This medial thalamotomy target another part of the ascending nociceptive pathway. It's the medial part that is a relay for the medial nucleus in the thalamus of the motivational affective component of pain that is responsible for the suffering associated for pain, for all the psycho-emotional reaction associated for pain. Then, after the relay in the medial thalamus, this pathway project to mainly the limbic cortex and also the prefrontal cortex, where suffering is initiated. So this medial thalamotomy for neuropathic pain is not a new procedures. First have been described by Jung in the 90s with using gamma knife thalamotomy. Previously, there are some trials with direct thermo lesion with using a props, but until the 90s and the early 21st century, no, it's non-invasive lesion by transcranial techniques that have been used by gamma knife or no with IFU, as it's been described initially by the Swiss group of Jean Monod. You can see the result of Jean Monod with next 100 patients with a follow-up of 4 years with a pain relief of more 60% in half of the patient. And in this group, there is approximately 60% of the patient with peripheral nerve lesion. So have used this technique to treat peripheral neuropathic pain and with what we can say a more or less good result. Complication rate was low, on 11% is only sensory disturbances like paresthesia that have been described by this group. So to resume medial thalamotomy, what is the good points? It's non-invasive under local anesthesia, whatever be the technique, gamma knife or IFU. Lesion could be controlled under MRI for IFU. It could cover a large painful area if you need. Morbidity is low, and there is no modification of sensibilities induced by these techniques. And the follow-up is very simple. What is not so good is not a technique easily accessible. You need to have a gamma knife or an IFU. It's costly. It's not accessible everywhere. And there are practical limitations for IFU. It's the disponibility of MRI. For example, in my center, it's a good limitation. We have no possibility of IFU because we have no enough access to MRI, actually. And we lack of series with long follow-up. So it's difficult to give recommendation, actually, concerning medial thalamotomy. So to conclude, there is no single treatment modality to manage this type of peripheral neuropathic pain. So it's recommended to tailor stepwise treatment coming from, as we saw, medical treatment, see if the restorative potential techniques possible for the patient. Then neuromodulation is a first-line treatment, and there is a small place for lesional techniques only. So rigorous selection is a key of success, as for all functional neurosurgery, and mainly for this kind of management. Thank you for attention.
Oh. Thank you very much. That was wonderful. That was wonderful by all means, Professor Mertens. That was very good. Final talk for our small seminar. Any question for our presenter.
Yeah, if I can,
Please.
thank you, Professor Mertens. That was excellent indeed. I was triggered about your results for the phantom limb pain for the dress procedure. And I was wondering, we have limited experience with doing a dorsal rhizotomy for persistent lumbar root pain when there's no residual disc herniation. So what we do is we open the dura and then we selectively transect the sensory vesicle. Do you think that would also be possible for phantom limb pain?
For phantom limb pain, I think it's a place mainly for neurostimulation. As Dr. Rimas present, spinal cord stimulation is not always efficient, but some groups use motor cortex stimulation, for example, for this kind of pain. We use only dresotomy after amputation, where there is some pain and pain like allodynia, paroxysmal pain, with induced that there are more or less hyperexcitability at the level of the spinal cord that we can try to control with dresotomy, but with inconstant effect on the phantom limb pain. So I don't recommend dresotomy for phantom limb pain. Try to start with neurostimulation first, and then if there is a component added like stomach pain with paroxysmal pain, okay, why not? And as you said, we are also very prudent when we have to cut nerve because make lesion of nerves that have been themselves previously injured could increase the afferentation and increase at least the pain. So I will be very prudent with lesion at the level of the peripheral nerve, whatever be the technique.
Yeah. Okay. Thank you. Yeah, we've had a small experience with the indication for persistent leg pain after lumbar disc herniation, where there's no residual disc herniation anymore. But you're right, there was a small percentage of patients who had an increase in pain due to the deafferentiation. So you have to be very careful with that. Thank you.
Actually, this subject was really very nicely discussed by 4 speakers. I thank all the speakers. And we are facing that problem as Goddard told us, especially in some after surgery, especially. Extraforaminal disc herniation especially are very prone to bring us some neuropathic pain patients. As you know, the spinal ganglia is compressing there, and then they are more apt to have neuropathic pain. What do you think about that? Shall we do in those cases? Shall we add some injections as well, foraminal blocks, epidural injections? What do you think about that? Yeah, we know that we are using gabapentin or pregabalin first stop, and then what must be the next option?
Well, I think doing those injections are reasonable. But if a patient doesn't respond to that, then surgical decompression and then modulation after that, that's kind of a pretty typical algorithm. I don't know that it's the only one, but that's a reasonable one.
Yeah, right.
At that point, I want to say that, Professor Zileli,
Yeah.
if the pain type is so important, if the pain type is like a nociceptive pain, and you have some concern about still there is a narrowing on the transfer, there is a suppression on the nerve, you may think about the surgery. But if the pain type is like a neuropathic pain, every additional surgery will increase the pain. Every additional surgery will take the patients to the very bad situation. In such these issues, you may use the transfemoral injection, and then you may think about the modulation.
Completely right. I agree this. I'm sometimes criticizing that people are indicating stimulation, dorsal cord stimulation surgery, even for back pain only patients. That if there is no neuropathic pain, back pain patient must not go to any stimulation procedure. I believe this.
Yeah, I'm with you about that.
It's a complex subject because there is no even some experimental data that bring us the concept that back pain is not only nociceptive pain. Obviously, there is nociceptive pain from the locomotor system, but also they could have neuropathic pain associated. And even some groups said that nociceptive pain, when it's become chronic and with a long duration, become neuropathic pain. There is a transformation of nociceptive pain to neuropathic pain because the nociceptive pain induce a definitive transformation of the nervous system on the nociceptive pathway and on all the controls. And we are not in case of peripheral nociceptive pain like cancer pain or something like that. That could be complex also in their physiopathology. So it's not so easy to distinguish nociceptive from neuropathic. But I agree with you. Spinal cord stimulation is not perhaps a good response for back pain. It's not always a good response for back pain, but it's very controversial. There is big discussion about that concerning this fact. But we have to work about that still.
If you allow me, I have a question to Professor Martinez about going with unilateral laminectomy for the DREZ procedure. Sometimes you have a traumatized spinal cord, and do you have some like sort of a way to have your landmark when you go with a unilateral approach to identify your area of entry? Going from unilateral, doesn't that make it more difficult and more when you have more and more cases done that you can do that? And for a starter, you better do bilateral laminectomy and identify your landmark, especially when you have a traumatized spinal cord.
Yeah, yes, you're right. At the cervical level, it's not so difficult because the dorsal rootlets are separated from each one another, and you can anatomically differentiate its roots from each one another. It's not the case at the lumbosacral levels, or all the rootlets are in a continuous organization. So we use, I don't speak about that, we use electrophysiological monitoring if it's possible. It's no more possible if there is some avulsion, for example, or complete deaffermentation, but we use electrophysiological monitorings. And for brachial plexus avulsion, we we perform unilateral, but we start the laminectomy at C3 to control the C4 roots and to stimulate C4 to be sure that it's C4 with diaphragmatic responses. And then if we have C4, we know exactly all the rootlets underneath. Even there are a number of rootlets, we can find the correspondence entrance of the roots in the dura, and we can have clearly each levels could be controlled and identified.
There's another potential solution as well. Obviously, you don't want to do a full bilateral laminectomy since you want to preserve the posterior tension band and prevent kyphotic deformity. So in the US, what a lot of surgeons do is a laminoplasty to allow full bilateral exposure following an intradural opening. But then when you finish, you then plate the spine back together so you have preservation not only of the posterior interspinous ligaments, but both layers of muscle as well. So that gives you bilateral exposure without destroying the posterior elements of the nerve, the muscles and bones and whatnot.
Yeah, you're right. It's a good solution also.
A quick question, Professor Mertens. When you say low intensity, so what do you mean? How high in temperature do you go for how long?
To be honest, we still use the Melis machine, dipolar stimulation machine that is no more produced. It's allow you a very low intensity coagulation, microcoagulation. We have tried a lot of machine, and a lot are not adapted to what we want to do. And I perform also a lot of spinal cord tumor surgery, and the problem is the same. We want to have very small intensity coagulation inside the cord, and so I'm very lucky to have still an available Melis machine, but I know that she will die in a few months or few years, and I don't know what I will do after the disparition of this machine, because I have no the equivalent actually offered by the company. With this very low intensity coagulation, it's not the case necessary for the surgery we discussed today, but you are able to coagulate the side of a vessel without coagulate completely the vessel. You can do a lot of stuff very precisely, but it's not possible with actual machine. It's a pity.
Thank you.
I think we're getting to the end. If there is no more questions, we have been for almost 2 hours now, almost 2 hours for our webinar. We have a good amount of online attendee, and I'm sure it will be in the library, and we will have an archived, and people will come back to it and will be able to listen and see the presentation and give the knowledge they want on a specific topic that has been presented today. Professor Zalili, do you want to conclude and thank the presenters? I'll give you the microphone.
Yes, it was great to meet you all. Really very nice talks. I enjoyed it a lot. Thanks to all speakers and moderators. Wish to see you in future actions. Goodbye.
Thank you for having me.
Thank you.
Bye.
Good luck.
Thank you, everyone. Thank you.
Bye.
Bye-bye.